This is a podcast for Nursing 242 for the second half of the intrapartum lecture. Okay, pain in labor. So we say that pain in labor is pain with a purpose. It's pretty much the only time in your life where you experience pain and it's for a good reason versus when you have pain is typically a reason to seek medical treatment because it's a sign there's something wrong in your body. Lots of different relief measures we're going to talk about. The natural measures, so things like hydrotherapy, hypnobirthing, Lamaze, the Bradley method, comfort, massage, different things to help patients cope with labor. Then there are narcotics and, of course, epidurals. So one of the best things that we can do for our patients is get them up out of bed, moving around as much as possible, frequent position changes. If that's not a possibility because the patient needs continuous electronic fetal monitoring, we can still frequently change their positions within the bed. So non-pharmacologic methods are hypnobirthing, which is basically a form of self-hypnosis to help a patient relax and cope and tolerate labor. Lamaze is the traditional breathing and relaxation that patients can do during labor. Hydrotherapy and sterile water papules are on the next slides. So hydrotherapy or water birth, so there's two options. Patients can labor either in the tub or the shower and or potentially deliver in the tub depending on the facility. Lots of advantages to hydrotherapy. Helps relieve pain, gives a patient greater comfort and mobility for mom, much more efficient labor, less of mom's energy is wasted. It makes it easier for mom to breathe and kind of relax. Also gives her privacy, which can be helpful, especially if she has a lot of people present at her birth. Can help lower her blood pressure. There tends to be less maternal trauma when they deliver this way because it allows the perineum to stretch easier. It creates a much more gentle transition for the baby, going from a warm fluid-filled environment to a warm fluid-filled environment. And it definitely helps reduce the cascade of interventions that can occur in labor. Sterile water papules are basically 4 little spots that we inject a very small amount of sterile water right under the skin. And basically what it does is it confuses nerve pathways. So if we inject 4 tiny little areas of sterile water, it causes pretty intense burning right under the skin. So it confuses the nerve pathways. The patient becomes more focused on that than on her labor pain. Lots and lots of narcotics that we can use and some other methods that we can use in labor. Some of the more common ones that we use are Nubain and fentanyl. Morphine is typically not used unless the patient is in very, very early labor because morphine has a longer half-life and is much more likely to cause respiratory depression than some of the other methods. Benadryl, a lot of times we will give in conjunction with a narcotic to help with some of the itchiness and nausea that can go along with narcotic administration. Ambien we give as a sleep aid, especially for patients who are coming in for induction of labor. Nitrous oxide is becoming a little more popular. The Pinnacle facilities are starting to use it now. It's essentially laughing gas. So it's self-administered. A patient will have a mask that she can apply. As soon as she starts to feel a contraction, she'll breathe in the nitrous during her contraction and then remove the mask at the end of the contraction. There are basically no known fetal side effects to using nitrous. It's very, very safe for mom and for baby with very little known side effects. Some hospitals are resistant to using it though because by using this method, it might actually prevent patients from getting epidural anesthesia, and epidural is a big moneymaker for hospitals. When we're talking about narcotics and giving them, we always want to think of safety. If we're going to administer a narcotic, either IM or IV, we want to make sure that certainly prior to administration, we've had a reactive non-stress test, that the patient has been up and emptied her bladder, that she's settled in bed in a nice comfortable position, her call bell is within reach, and she knows not to get out of bed. Narcotics will not completely take away labor pain, but they will dramatically take the edge off, help the patient relax and rest in between her contractions. Narcotics do cross the placenta, so some of that effect will reach the baby. So we also need to be mindful of that and thinking about timing of delivery. If it appears that delivery is rather imminent, then narcotics might not be the best method to use because of the potential to sedate the newborn. If mom has received an opioid narcotic and the baby is sedated at delivery, we can give the baby Narcan to reverse that. We need to be careful, obviously, with Narcan administration, though, because if the patient is an unknown opioid addict and we give her Narcan, it's going to immediately put her into withdrawal, which can have effects both for her and the baby. Another important thing to note is that Nubane should not be used in anyone that you have suspicion or knowledge that they're addicted to opioids, because it has like an agonist-antagonist effect. So it actually, even though it's narcotic and provides pain relief, it can also trigger withdrawal symptoms in someone who is addicted to opioids. So epidural anesthesia is probably the most popular form of pain relief in obstetrics. Lots and lots of side effects and risks that are associated with epidural anesthesia. The most common one that we see is maternal hypotension, which is why you'll see patients getting that IV fluid bolus prior to receiving epidural anesthesia to try to kind of bump their fluid volume up some to help hopefully prevent the hypotension that results as an effect of the epidural. If we have hypotension, if mom drops her blood pressure, organs aren't going to perfuse well. That means the placenta won't perfuse well, and we can see some fetal distress. Epidurals sometimes are the first piece in the cascade of interventions in obstetrics. If you have a patient who's laboring normally and then she decides she wants an epidural for pain, well, epidurals can slow down labor. So then we have to think about maybe breaking her water or starting oxytocin, both of which carry some risk. If we break her water, increases her risk and baby's risk of infection. If she has an epidural for a period of time, she's not going to be able to feel to pee, so now we have to put a Foley catheter in. So that's going to increase her risk of a bladder infection or a kidney infection post-delivery. It's a little more difficult to push when you have an epidural, so it increases the risk of potentially needing an assisted delivery with vacuum or forceps. So all of these things start to increase the risk. Every time we do one intervention in labor, mom is more and more and more likely to need another intervention and another intervention to get through labor. So with an epidural, mom's either going to need a Foley or need to be straight cath at some point. The epidural might not give the patient complete relief. Sometimes they only work on one side, or you'll have a window where you still feel pain. There's medication side effects, obviously, like any other medication. There's the potential for anaphylaxis or other reactions. A common side effect to the meds in the epidural is itching. Patients will sometimes feel very itchy, can slow the progression of labor. Certainly, anytime we're injecting anything into anyone's body, there's a risk of bleeding and infection. We've talked before a little bit about platelet counts and epidurals. Ideally, the patient's platelet count should be at least 100,000. If it's less than that, then there's a high risk of bleeding when we place the epidural. And then the one side effect that we don't mention enough is that death is a side effect of an epidural. It's very, very rare, but it can happen as a result of infection or reaction to the medication. Sometimes the epidural block will go too high. The patient can go into respiratory arrest. So benefits of epidural anesthesia, obviously the pain relief. The patient can be alert and oriented and awake and have good relief of pain so that she can feel more in control of her body and her labor process. For patients who have previously been victims of sexual assault or abuse, sometimes getting an epidural very early in the labor process will help them be able to cope a little bit better with their labor. So second stage of labor, so when we're pushing, frequent position change is important. Patients should hopefully feel something to help her to push. So even our patients with epidurals should hopefully at least be feeling a little bit of pelvic pressure. It's incredibly hard, especially for a first-time mom, to know how to push a baby out if she can't feel anything at all. Likewise, on the other side, if she doesn't have any anesthesia on board, you can't expect her to not push if she's completely dilated and she has an urge. So sometimes that can be a problem if you're in a facility where the patient's provider isn't readily available to come to the room when it's time for delivery. And then normal time frames. So there's no right or wrong answer to this. Certainly it takes longer typically for a first-time mom than for someone who's had a baby before. But things can change. If the baby's bigger than her last one, things like that, that can impact how long it takes. The rule of thumb typically is if a patient has been pushing for 2 hours and has made 0 progress, so the baby has not moved at all, despite you coaching her, changing her position, trying different things to help her push well, then that's usually an indication for C-section. But if a patient is making good, slow, steady progress, I've had patients who have pushed for 4 hours or even a little bit longer before. What the literature says, as long as mom's okay, baby's okay, there's no signs of distress, infection, anything, and they're making progress, then moms can really push for an extended period of time. So different positions we can get moms in for pushing and in for birth, squatting, on all fours, side lying. Certainly if she has an epidural, she can't really get out of bed to push, but we can change up her position within the bed. For those of you who have actually gotten a chance to see a delivery, you might have taken note of the cardinal movements that babies need to do to negotiate their way out. They don't actually just come flying down. They have to do some turning and some negotiating as they make their way down. So the movements that they go through, they have descent. So the baby's got to actually descend down into the pelvis. Then we have flexion, where the fetal chin is going to flex down onto its chest. So they tuck their little heads in to fit through. Then there's internal rotation, so the fetal head's going to rotate to fit through mom's pelvis. So this is why we typically like those babies to be facing down when they come out, because it gives them more room to get through the pelvis. Then there's extension, so that's where the fetal head actually comes up under the pubic symphysis and the head starts to emerge. The interesting thing that they do after this, after the head emerges, you'll have restitution, and that's where the neck is going to turn and it's going to line itself up with the shoulders. And then the last things that are going to occur is you're going to have this rotation. The baby's going to rotate itself either to the right or to the left, and then you'll have expulsion. So that's where that anterior shoulder, the top shoulder, is going to slip out from under mom's pubic symphysis, and the baby will be delivered. Third stage of labor, so those of you who have seen this when we're waiting for the placenta, there's 2 ways it could be done: active management or just waiting. So active management is when you'll see the healthcare provider giving a little gentle traction on the umbilical cord, maybe massaging mom's abdomen to encourage the placenta to detach, and some will just completely keep hands off and just wait for it to occur. Both of those are normal, acceptable practices. You'll see typically we give some type of medication with the delivery of the placenta to help the uterus contract down after delivery. Most commonly we do oxytocin or misoprostol. And then we've talked before about normal blood loss, 500 up to 500 after a vaginal delivery, up to 1,000 after a C-section. When the placenta comes out, it typically is going to come out either the fetal side up or the maternal side up. So the fetal side is what we call the Schultz side. It's the shiny side, the really pretty, if there is a pretty side, the pretty looking side, where that's basically baby side of the placenta. The Duncan side is the maternal side, and that's the one that looks like liver. So that is the part of the placenta that was actually attached to the wall of the uterus, and that's what we're inspecting after delivery to make sure it's all intact. It looks healthy. It doesn't look calcified. Calcifications basically are like white, hard, gritty areas on the placenta. We can see calcifications in people who have gone over their due date, people who have hypertension, and smokers are some of the more common ones. So just to recap, assessments we do immediately after birth. Obviously, we're assessing the baby, doing APGARs, resuscitation if necessary, and observing that that baby is transitioning normally. And for mom, we're going to start doing her blood pressure checks, her fundal checks, bleeding, pain assessment, and helping to facilitate bonding between mom and baby. So there are some NCLEX review questions at the end of this that you guys can work on yourselves, and then we can certainly discuss the answers in the classroom. And that is the end of this podcast for Intrapartum.